Hello, thank you for joining us this afternoon. As always, we're going to give it just a minute to allow the room to fill up before we get started. I hope you're having a wonderful day today. Thank you for joining us. Give it just a moment before we get started. All right. Good afternoon. We are just giving the room, or we're just taking a moment to allow the room to fill up before we get started. But thank you so much for joining us this week again. Okay. Good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on the challenges of assessing and managing pain. My name is Alson Murtha, and I am the Manager of Strategic Communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning Friday, July 1st. I am joined today by Dr. Nathalie Roussel. Thank you for taking the time to join us. I'm going to go ahead and turn it over to you to get started.
Okay, thanks a lot. So the title of the presentation of today is the challenges of assessing and managing pain. I think it's a big work, and I'm very happy to be here. So many thanks to the organization for inviting me. I work at the University of Antwerp. It's located in Europe and in more particular in Belgium. It's a very small country or a region between France and Germany. And we are very proud of our national soccer team, which is famous, our buildings, also the beer. We have more than 300 active breweries and a mean consumption of 68 liters per person. As I'm not drinking beer, it means that my husband needs to drink the double. And in Antwerp, we have the World Diamond Center. So should you have some time, do not hesitate and come to visit us. These are my disclosure because I'm not here to discuss the tourism of Belgium, but to discuss the challenge of pain. And I tried to structure the presentation regarding three themes. For me, there are three challenges, and the first one is the understanding of pain. And I think I'm a little bit provocative by starting with a couple of misconceptions regarding pain, but I think it's maybe a good start to open the discussion, because many myths or misconceptions exist and they hamper proper pain management. I will go on then with the assessment of pain and then end with management of pain or pain relief. And as you all know, pain is a common problem, not only in people with hemophilia, but in the people with bleeding disorders in general. And for me, the first misconception is related to the cause of pain. And in people with hemophilia, there is typically a distinction between pain related to bleeding and pain related to joint damage. And that might be the case, but people forget that there is more than that. More factors can influence the pain and can be linked to pain fluctuation or the transition from acute pain to chronic pain. So for me, it's a misconception to consider pain only as a cause of bleeding or as a result of bleeding or joint damage. It's more complex than that. And the second misconception is to link every increase of pain intensity to bleeding. So this is really learned in the community. It's that if you feel an acute increase in pain intensity, it's acute pain and hence a bleed. And this is not correct. And we see that in a lot of patients, of course, without hemophilia, that suffer from chronic joint damage, that they have a pain intensity that changes over the day or between the days. And you can have an increase in pain intensity without any bleed in the joint. And this is the case in people with hemophilia as well. And that has been demonstrated by Seponis a couple of years ago, that in people going to the emergency department with a presumed bleeding, actually the majority do not have a bleed. So these fluctuations in pain intensity are perfectly normal and can happen without any bleed. So it's not correct to consider an acute increase of pain intensity to link it to a bleeding. And the third misconception is to consider pain, for example, ankle pain, which is very, very common in people with hemophilia, as a local problem. You see a quite complicated graph for those not familiar with the neurophysiology of pain, and I will try to simplify it. So in brief, if you have a bleeding, if you have an inflammation, if you have a joint damage or any other problem in the ankle joint, there will be a signal of danger. And the signal of danger that is represented on the here, that is represented here, will be transmitted to the spinal horn in the spinal column by nerves. And this electric activity will be transmitted to the brain regions, provided that the stimulus is of sufficient intensity. So in the ankle joint, it's a kind of message of danger. It's not pain, it's a danger message, a kind of warning signal that is transmitted to the spinal column. And from there is a nerve that goes to the brain. And from there are different brain regions that are activated. And it's only when the signal arrives in the brain that you can speak about pain, because if it doesn't arrive in the brain, then you do not feel any pain. And this is by a marvelous system of our own body that is actually, just see why the slides are not. Yeah. So in the red arrow, you see the information that informs the brain about these signals, but we also have a blue pathway that goes from the brain to the dorsal horn, to the spinal column, and that can influence the transmission of information. So we do have our own pain control system that is depicted in blue, because information from the brain can go downwards and influence the transmission of information in the spinal column. And you can really consider it as a kind of blocking mechanism. So the blue line can block the information in the spinal column. And if the message is not given to the brain, you will not feel any pain. And this system functions very, very well, but is dysfunctional in people with chronic joint disorders. And that was the reason why we assessed the relationship between the local joint damage and the pain intensity in a group of 30 people with hemophilia. And you see the results here. So it's a study that has been published, and we had an assessment of 60 ankles. So we had MRI, so magnetic resonance imaging, to see the joint damage. We had the HEDIS score, we had functional aspects like the HHS, and we had the pain intensity. And we did not find any meaningful correlations between MRI scores of joint damage and pain intensity. And this means that also in people with hemophilia, like in other people with chronic joint pain, we need to take into account the nervous system and the brain. And this has not been done before, and I think it's a large mistake. So in people with chronic joint pain, such as osteoarthritis or other joint problems, we really see the involvement of the nervous system and the brain, and we should target it in the assessment and the management of pain, not only stick to a local evaluation. And this is maybe more clear in this slide, because pain is of course not the only symptom. In the case of osteoarthritis, you have decreased mobility and decreased muscle tissue, and that's I would say pretty the same in people with hemophilia and hemophilic arthropathy. You have this increased stress on other stuff, such as joint capsule, cartilage and ligaments. But you also see in blue that you have a kind of sensitization of the system. And that's like an alarm signal that is going louder and louder and louder. If it decreases the sound of your wakening alarm in the morning, you will fall asleep again. So this sensitization of the system, where an increased pain sensation is created, is perfectly normal in the acute phase, because it means that we will pay attention to pain and that we will avoid loading the joint. And in an acute situation, this is a very good reaction of our system. But when this system becomes dysfunctional and this increased sensitization takes much more time, so it means that it's not only during the healing phase, but also taking longer time, then we have an increased pain sensation, although it's not functional anymore. And this is what is happening in a lot of people with chronic joint pain. It's the sensitization of the nervous system, meaning that you have an increased responsiveness of the central nervous system to, let's say, some signals. And finally, the last misconception is that assessing the pain intensity is a real pain assessment. You have to consider that pain has these consequences, such as influences on muscles, on movements, on joints, but also on normal function. And that's something that can lead to emotions such as anger, frustration, or maybe helplessness. And in the end, you have a vicious circle of chronic pain affecting sleep and, of course, quality of life. So limiting the assessment of pain to the pain intensity is an important misconception. But maybe it's good to stick to the definition to pain. What is pain? And pain researchers, it took them 20 years to have a common definition, and they define it as an unpleasant, so it's not fun, sensory, but also emotional experience, meaning that it's perfectly normal to have negative emotions associated with pain. And this experience is associated with or resembling that associated with actual or potential tissue damage. So that means that it's unpleasant sensation. It's not only sensory, but also emotional. And there might be tissue damage, but it's not necessary to have tissue damage. So if you remember the sensitization of the system, it might be the consequences of acute tissue damage in the first phase, but you might have a healing processes of the local joints while you keep the sensitization of the system. And this leads to chronic pain. And so the International Association for the Study of Pain also highlighted 6 key messages. And I think it's very, very important to consider them when you or before assessing pain in any individual. So what do they say? First, pain is always a personal experience. So it's very, very individual, and it's highly influenced by biological, psychological, and social factors. And that's perfectly normal. So we need to take into consideration that biological, psychological, and social factors will influence pain. The second message is that pain and nociception, it's the word we use to refer to this kind of electrical signal transmission, are different phenomena. So it's not the one-to-one relationship between the activity in the nerve and the pain intensity. During their life, people learn the concept of pain, and we should respect the person's report of experience, of pain experience. So we should not doubt about their pain intensity or their experience. It belongs to them, and we just need to record them. And then the fifth one, although pain serves an adaptive role, it might have adverse effects on function, social, and psychological well-being. And that's when it becomes chronic, of course. And the last one, that you all know that verbal description is only one part. So what I get from my patients is the next question, and they ask me, so Nathalie, do you think pain is in my head? And the answer is yes, because the complexity of pain makes that the brain is involved in pain. It's necessary that the brain is involved in pain, and the brain is always located between the ears. So yes, the answer is it's between the ears, it's in your head, but I do not know anyone without the brain functioning properly, so I think it's not a problem. Just to give you one example of how the brain can misinterpret some signals, please have a look at the following slide. You see a kind of a game, I would say, with a green bar. And if I ask you which is the color of the box with the letter E and which is the box of the letter B, the majority of the people will tell me that the box with the letter E is dark gray and the box with the letter B is light gray. And it's simple, we know the pattern of these games, so our brain is used to this pattern. And actually it's not correct. If you look at a gray bar that goes from box A to box B, you see that it's actually the same color, but there is some shadow from the green box, and you see that only the color of the letter is different, not the color of the box. If you have a closer look, this is exactly the same color and this is exactly the same color. So both boxes have the same color, but our brain is, I would say, used to see differences, and with the shadow here of this green box, we are misinterpreting some information. So it's highly important to explain that to patients, that it's not because they feel pain that it necessarily means that there is joint damage. And this is because of the brain that is used to link pain with tissue damage. So this was the first challenge, to understand pain. Of course, it was very brief, but I think I covered the main messages. And we now have to assess our patient with pain. And of course, in people with bleeding disorders, the first priority is to confirm or to exclude a bleed. That's no question about that. But even in case of a bleed, or even if a bleed has been excluded, we need to assess the person with pain. And it's much more than only the pain intensity. And this broad assessment is the only way to continue or to set up a proper pain management plan. So when it comes to pain assessments, literature has shown us that under assessment of pain, if you do not take enough time and if you do not assess all these influencing factors, remember biological, psychological and social factors, it is the cause of inadequate pain management. So yes, assessment of pain is extremely time consuming, but it's the only way to set up a proper pain management plan. And the second important point about pain assessments, we know from the definition from the International Association for the Study of Pain that pain is a subjective or personal experience and that it's multidimensional. So pain assessment should include physical and psychological assessments. So in the clinical practice, I listen to the patient's history. We use questionnaire and we also use clinical tests. So I think that's a kind of structure we can use to assess pain in people with hemophilia. And on the right side, you see the title of a paper that was published last year by the group of Paul McLaughlin. And I like this title because in the first sentence, the lifetime of painful experience of people with hemophilia is pointed out. And I think it's important to really, really ask the patient about his painful experience. Do not forget that elderly patients with hemophilia, they suffered for many, many years and they try to cope with the pain. And this is maybe something we should see, is that people with hemophilia, they are the real pain experts, but maybe they have done some coping strategies that are not helpful. And that's the reason why, as pain scientists, we would like to take the time to discuss these. So this is, of course, not something I have developed myself, but I think it's good to see a little bit an overview of questions you can ask during the subjective history taking. Of course, the first box about the pain characteristics, I think everyone knows these questions. But I'm more interested in the management strategies that the patient has tried out himself. And of course, people ask about medication, but I'm very, very interested in the non-pharmacological treatments. Let's say in everything they maybe do without informing the physician. We do have patients who drink alcohol, who take illicit drugs, who try to do as many as distractions as possible. I heard a patient putting heat on acute pain linked to a bleed because it was just altering the sensation from cold. So he was just switching heat and cold. So what I like to know, without any judgments, what is the patient is doing with the pain. Of course, we will ask the relevant medical history, the relevant family history, but also a lot of psychosocial questions. We do know that a lot of stressors can influence the intensity of the pain. So if the person is currently undergoing a stressful period, if the person is in a difficult personal situation, this will affect the intensity of the pain. And it's perfectly normal. There is a biological explanation by the brain regions, such as the prefrontal cortex, which is a brain region influenced or affected by these danger messages, but is also linked with the cognitive aspect of pain and the emotional aspect. So I think we should take the time to ask these questions because it's afterwards part of the pain management plan to deal with that. Of course, the impact on the person's life, and we performed a study recently where we asked people with hemophilia if they had an altered quality of sleep, and the reaction was amazing. And when we asked if it was discussed during consultation, the answer was no. So no sleep assessment is done in people with hemophilia. It's not discussed, although it's sometimes the reason why they go to the physician to ask for a knee prosthesis, because it's altered sleep quality. It's not the mobility, it's sometimes really the quality of the sleep. And finally, the patient's expectations, because they can be too high or too low. And that's also a problem if the patient has no or has too high expectations of the treatment. So again, this is time consuming, and that's the reason why we should work in a multidisciplinary team. But this is extremely important to make this inventory, to gain more insight into the personal history of the person suffering from pain. Regarding the questionnaires, of course, as researchers, we do love questionnaires. As clinicians, we hate them. So it's always a hate-love relationship. But do not forget, or please remember, that scales such as the visual analog scale or the numeric rating scale, or in children the Wong-Baker FACES scale, it's only about pain intensity, and it's just a snapshot of the moment. It says nothing about the cause of pain. It says nothing about the past pain, the consequences of daily life. It just evaluates the pain intensity of that moment. And people do hate that, because pain is much more compared to what they feel. For me, the body chart is interesting. As a pain researcher, we are used to assess part of the body that is painful. And on the left side, I put a graph from a study performed in people with low back pain. And you see in yellow the painful areas, and the darker the color, so the more it's going to red, the more people indicated that region as painful. So unsurprisingly, in people with low back pain, it was the lower back that was the most painful region. But what interests me is that in some people, you see that half of the body is colored, meaning that they suffer from pain all over these regions. And this might be the first sign that something is wrong with the central nervous system, that you have this kind of overreaction or increased sensitivity of the system. And in people with hemophilia, on the left side, you see the graph with the different bars. It was shown 20 years ago that more than 30% of people with hemophilia suffer from pain at more than 5 locations. And again, this is sometimes considered as a kind of cutoff to see if widespread pain might be present, meaning that the central nervous system is involved. The research is currently going on to gain more insight into how questionnaires can be used to assess this involvement of the central nervous system. But as long as they are not validated, I will not present them. But this is really work in progress. So you should be careful, because I expect that the next 5 years there will be major advancements also for people with hemophilia. And finally, for me, a really, really important questionnaire is the illness perception questionnaire, because these questions really tackle how the person thinks about pain, how it influences his daily life. And the questions are really, really easy to answer. They are answers on a score from 0 to 10. And you see that some of these psychological constructs are included in this questionnaire. So, for example, how concerned are you about your illness? Or how does your illness affect you emotionally? And this questionnaire is developed and was validated by a large team of researchers. And we are allowed to switch the word illness by pain. So it makes sense in people with hemophilia to replace the word illness by pain, to see how they think and they feel about their pain. And this gives us very interesting information, again, that we will try to include in the pain management plan. And finally, a lot of questionnaires exist to assess the activities of daily living, quality of sleep and quality of life. But I think at least the questionnaires assessing quality of life and daily living are well known. So I will not go into detail. But for me, the main purpose of this assessment, as I said, it's a broad assessment where all biological, psychological and social factors are included. And if you see the biological factors, you will be familiar with these aspects. So these are the factors people ask about pain, such as the hemophilia severity, the status of the joint health, the access to prophylaxis, comorbidities, the bleeding, but also the psychological aspects. It's really important to ask about the concerns, the worrying, the behaviors, their experience, mental health, and the interactions with healthcare, and also the social aspects. And the purpose of this broad assessment is to make a kind of individual picture of the patients, because pain, it's like I would say in a relationship, it's very, very individual and very personal. So you cannot just translate it to someone else. So this is the example I use with my patients. It's to find out a kind of personal identity card of the pain of the person. And all these aspects will be covered, and I will try to explain to the person that pain is the consequences of many factors, of multiple factors, not only the consequence of structural joint damage, because this was the misbelief I started with. In people with hemophilia, a lot of people think that pain is the direct consequences of a structural joint damage. And you see in this very, very simple graph that inflammation, lifestyle, maybe malalignment of the joint, misbeliefs, deconditioning, and fear and anxiety may play a role. But this scheme will be different for each individual. In some people, obesity will be included. In other, they are too motivated and they are excessively sporting, and maybe that's contributing to the pain because they exceeded the loadability of the system. But this is really important. It's to individualize the approach, to have a very personal, I would say, assessment of the person in pain. And finally, the management part. And this is, of course, the most difficult one. And this is really, really work in progress, because we are only now gaining more insight into the assessment of people with hemophilia. But I think I can bring you some messages from other joint pathologies, such as low back pain or osteoarthritis, to see in which direction it might go. And you see the words pain relief, but you also see that different persons are taking a different part of the puzzle, because I strongly believe in a multi-dimensional approach, in a multidisciplinary approach. I think it's really, really important when you deal with such a complex problem of pain to have different disciplines involved. And that would be my question to all of you, is to try to see how you can set up collaborations. Because, of course, it's not the purpose that hematologists do all the work themselves. We really should try to do the work together. But we also need to give the same message to the patient. If the hematologist is telling the patient that the joints are damaged and that they should be careful during loading of the joint, and I, as physiotherapist, say that loading is really, really important and that they should do some exercise, we give a contradictory message to the patient. And that's the best way of having or decreasing the adherence to the treatment. But I think that's perfectly normal. If we do not give the same messages, then the person will lose trust in us. So that's really important to speak about the pain and the problem in a multidisciplinary team. And again, I would like to refer to a qualitative study of Paul McLaughlin about these experience and beliefs of people with severe hemophilia, about pain management and about exercise as part of the pain management plan. And what they conclude is that musculoskeletal joint pain is still a management challenge. I think that's not a secret. But they also highlight the fact that pain management strategies are very, very, I would say, unimodal or limited to one aspect, instead of this multimodal pain management plan. So I think as a community, we really need to do better our job to increase the pain assessment, to have all these modalities or influencing factors inventoried, so that we can set up a multimodal pain management plan, because currently it's not the case, or only in a very limited number of people. And if we have this nice graph of what is contributing to the pain, then I think it's not so difficult to set up these different parts of the pain management plan. If we have misbeliefs, then we can use information and communication to correct these misbeliefs. And of course, that's not a finality. It's just to increase the treatment adherence. We can use exercise and physiotherapy to have this local effect on the joints, but also to target the central nervous system effects, and I will deal with that in a minute. We can have a psychosocial intervention. Of course, surgical options might be very good options. For example, in the knee, in the ankle, we know that they have less effect. Of course, medication is an option, lifestyle, and also all the breaks and adaptations. But it means that it's a combination of different modalities rather than to stick to one single modality. And I think the challenge is also a chance, because in hemophilia or in a lot of bleeding disorders, this multidisciplinary approach is really, really existing and functions well. So we need to use that. I will start with information and communication, because I think that's maybe the easiest part to set up. And we all know the quote, no pain, no gain. But I would like to propose you an alternative. It's no with a no pain to have a better gain. And I think knowledge of pain, it's not only important for healthcare providers, but also for persons. And again, I refer to the study of Paul McLaughlin. And the people involved in this study really said it was extremely important that pain was managed by someone whom they trust. So these people with a lifetime experience of bleeding and pain and medical problems, they really are confident in their hematologist, in their nurse, or in their physiotherapist. And so I think it's our responsibility to explain what is pain and how all the terms you see on this slide might contribute to their pain experience. So the fact that they are worrying might increase the sensation of pain. The fact that they have consequences on daily life, maybe also on a financial aspect, might influence their pain experience. Pain management should be individualized. So I think it's really, really important to discuss this in detail. And we can use very, very simple metaphors. Here you see that, for example, a glass of water, and you see a lot of terms in this glass of water, and you can consider all these terms as a kind of stressors. And the fact that they are all present together makes that at certain moments the water will go out of beker in Dutch. I do not find the word of the glass, sorry, because it's a kind of addition of the stressors. So you see on the right side that if the person suffers from lack of sleep, from worrying, from fear, from tissue damage, and some stress, it all adds up, and at a certain moment there is just too much. And as I said, pain is really poorly related to structural damage. So this is good news, because it means that even in case of severe joint damage, it's not absolutely necessary to suffer a lot of pain. We've seen that in people with severe osteoarthritis. As I said, pain is highly multifactorial, so we should inventory all these stressors. And then we can explain to the person what is happening. So remember the fact that you have an addition of stressors. If we go back then to the sensitivity of the nervous system, we see on the left side, I will take the pointer, on the left side, you have a low sensitivity of the system, meaning that you have a lot of space for activities. But at a certain moment, if you have all these stressors that sum up, you will at a certain moment increase the level of excitement, and then not much is needed to increase this level of excitement or fire level, and then you will get this message to the brain. And this means if you keep this system in a sensitized state, that there is very little room for activities, and that this threshold will be exceeded a lot. And this is what is happening in a lot of people with chronic joint pain, known in osteoarthritis, low back pain, whiplash-associated disorders, shoulder problems, and so on, that it's about the sensitivity of the system. So the system, I would say the baseline is too high because of all these stressors, and the system adapts. And this means that not much information is necessary to exceed the level, and then the information is sent to the brain. Remember, if the brain gets the message of danger, they will consider it as painful. And you see also on the right side, the normal electrical level. So like in the beginning of the situation of this person, and it's possible to decrease the sensitivity system by different treatment options. And this is shown in the next graph. So here you see, for example, all treatment options that have been shown in people with chronic pain. So it's not, of course, people with hemophilia with chronic pain. We don't have these studies yet, but in people with osteoarthritis, fibromyalgia, whiplash-associated disorder, low back pain, neck pain, and other pain, musculoskeletal pain problems, that it's possible, thanks to this combination of treatment modalities, to decrease the sensitivity of the system. As a scientist, I'm used to give the reference for it. So I think here you see that it's not only about one study, but it's about a systematic review and meta-analysis, where this kind of pain neuroscience education was explored in adults with chronic musculoskeletal pain. And so this pain neuroscience education, it's explaining exactly these principles to the person with chronic pain. So it's making this individual assessment of what are the stressors, what contributes to the sensitivity of the system, and also what can be done to decrease the sensitivity by explaining how the body deals with this message of danger, and how we can use different options to decrease the system's sensitivity. And you see also that there is some good news and some bad news. If you look at the effects of this pain neuroscience education on the pain intensity, you see that some favors the pain neuroscience education, and sorry, this should be it favors the control. This is a mistake, but it's not very clear, because a lot of studies are including the zero, meaning that there is not a lot of effect. But you see that the effect on this PCS stands for pain catastrophizing scale, so it's a kind of scale for assessing the beliefs. There you see much more evidence that pain neuroscience education is able to change the beliefs about pain. And this is the first step to get a treatment adherence for the other components. And let me give you some examples. So these misbeliefs, like I pointed out before, are really hampering the fact that people will be active or adherent to the treatment. Also, the emotional factors can contribute to the maintenance of pain. So we should include them in the pain neuroscience education, and to see if this person needs some psychological help to deal with those stressors because of the known effect on the pain intensity and pain experience. And then we have the coping strategies. And we can broadly differentiate people based on two different coping strategies. The avoiders are those who are limiting activities, but we also have persisters, so they keep on going, and neither is good. And to come back on these psychological factors, they have an effect on this pain descending system. So this pain descending system, remember the first slide where I said you have a system that goes from the brain to the spinal column, to the dorsal horn. Its main function is inhibition. So blocking the information or the transmission of information. And that's the reason why we call it endogenous pain control mechanism, because it will decrease the pain. It's like a endogenous painkiller. But sometimes it is doing the opposite effect. It's going into facilitation. And this occurs when these psychological factors are present. So if a person suffers from stress, from negative feelings, or even depression, fear of movements of hypervigilance, you have this system, this blue system, that does the opposite of what we want to do. So they amplify the signal. So that means that more information is going to the brain, and hence the pain sensation is increased. So psychological aspect, misbeliefs, that were the first two aspects I wanted to discuss in the pain management plan. The third option is exercise and physiotherapy, and I'm very happy that this was shown before, that exercise is worthwhile for people with hemophilia to improve the function. Recent review also highlighted the relation with bleeding. But more and more evidence is popping up to show the benefits of exercise and physical activity as a pain decreasing system. And of course, it's not instant. So it means that you need a certain dosage of exercise before activating this descending inhibition. But again, what's the problem in people with hemophilia, and it's again the qualitative study by Paul McLaughlin, is that people with severe hemophilia may consider exercise as part of a pain management strategy, provided it's individualized and if it's done by clinicians who understand them and their hemophilia illness. So don't send them to a local physiotherapy not familiar with bleeding disorders, because they will not adhere to the treatment because of anxiety that they will do something wrong in the joint. So I think the modality of exercise and physical activity is currently underexplored in people with hemophilia as part of the pain management plan, but it should be done again in this multidisciplinary team where the trust is really present. And again, to explain how it works, it's not only about local effects on the joint, this physical activity or this exercise, but it's really about effects on the central activating system, because we know that physical activity will strongly increase the inhibition in the dorsal horn. Remember, inhibition means blocking the system. If the system is blocked, you will not get messages in the brain, and the brain will not be informed by something, so you will not feel pain or will feel less pain. And here you see the Cochrane evidence. I think if you have a systematic review of Cochrane Review, then there is plenty of evidence to show the benefits of physical activity and exercise. But we do know that to have these effects, and we speak about hypoalgesia, meaning that there is less pain after exercise, we need a certain dosing. And I think this corresponds to the recommendation of the World Health Organization that ask people to do 150 minutes of physical activity to have these benefits on their health. And it means that we really need to be careful to set up a management plan where the level of physical activity is increased, but stepwise, I would say, progressively. And it can take a lot of time in people with hemophilia. So that's the, I would say, drawback. They can increase their level of physical activity, but it takes 3 or 4 times more time than in a person without hemophilia, because you need to be very, very careful in the progression. So physical activity is really promising for people with hemophilia, but again, we have to tackle first the barrier, why they are not keen to do it, or why they think it's not helpful for them. And finally, the medication. We have, of course, possibilities to add medication in the pain management plan. And on the right side, you see the analgesic ladder of medication established by the World Health Organization. So in the first step, we use paracetamol or non-steroid anti-inflammatory drugs. In the second step, if it's not effective, we can add weak opioids. And in the last step, we can add stronger opioids. And this has been redrawn for people with hemophilia. So it was published in the guidelines for hemophilia of the World Federation. But remember, these guidelines are published without any experimental research. So if you ask me the question, what is a priority in hemophilia research? It's to examine the effectiveness of this medication approach. Because, for example, in people with low back pain, this paracetamol does not seem to help in people with low back pain. So we know that it's not efficient. And maybe in people with hemophilia, we are prescribing medication that doesn't function. So I think that's an aspect researchers need to take into consideration. We should do more research about the effectiveness of different medication approach in people with hemophilia suffering from chronic pain. And finally, this lifestyle approach, and as I said before, a lot of people with pain, including people with hemophilia, suffer from disturbed sleep. And you know all that if you do not sleep well, you are less concentrated. But it also has been shown that if you suffer from reduced sleep or altered sleep quality, that you are more suffering from more pain the next day. So after a very short night or a night where your sleep was interrupted, you are more sensitive to feel pain. So we know that in a lot of other situations, so we should inform people with hemophilia as well. That's just a bidirectional relation between pain and sleep, and it works in both directions. Pain can hamper sleep, and a lack of sleep can influence the pain experience. Finally, just a word, because it seems an evidence to us as pain scientists, but not to everyone, access to prophylaxis and adherence to a proper treatment plan with a prophylactic medication drastically reduces the risk of bleeding. So it should be considered as a preventive pain coping strategy. But in some people, this relationship is not clear and they are not so adherent to their prophylactic treatments because they do not know how it's related to pain. But I think if a proper explanation is included, maybe this might help to increase their adherence to prophylaxis. So this brings me to the conclusion. I think pain is really, really multidimensional, but it's not explained like that to persons. It's not assessed like that. So if you have one message that you should take home, or it's my question to you, could you take this take-home message, that pain is influenced by a lot of factors, and this opens perspectives for the management plan, because pain management can include a lot of treatment modalities. It should be done in team. I'm really convinced about that. And the purpose is to change the behavior of the person. And of course, the person needs to be motivated to start this behavioral change program. But if you explain it well, if you explain the benefits, if you coach the patient in pain, I think you can increase the self-efficacy and the belief that the person can change something, despite the fact that the joints are damaged. So a challenge, yes, it is. I think we accepted the challenge. Of course, it's work in progress, and I need your help if we want to tackle pain in people with hemophilia. It's not a personal job, it's a community job. And I would like to end with thanking all the sponsors that made the research possible, but I would also like to thank you for being here. And I'm very, very happy to be here together with you. And I will ask or answer the question with a lot of pleasure. Thank you.
Amazing, thank you. I am going to just share my screen, and really quickly, we actually have a couple polls that we would like you to participate in today. Those should pop up on your screen momentarily. Just 2 questions for you to answer. And while you work on that, I will start asking some questions to you. Let's see. With all of these misconceptions that you have described, how can we re-educate HCPs and patients about these issues and achieve better outcomes for people with hemophilia?
Okay, it's an easy question, easy to answer in theory and difficult to answer in practice. You know, all that changing the convictions of a person is not easy. And I think it's good to refer to science, because imagine the lifestyle, the lifetime experience of this person, where the advice was given that they were not allowed to do heavy physical work, that they had to rest in case of acute pain and stuff like that. And today we will change all these messages. Now that is very confusing if you do not explain that science has shown us that these approaches were not beneficial and increased the transition to chronic pain, or increased the pain sensitization of the system. So I really think that you should say to the person that new scientific insights have shown us new possibilities, and that it might be contradicting to what they heard in the past. We saw it with COVID as well. But if you link it to new studies, maybe you can have a first step. And the second step is, I think I personally use motivational interviewing to let the person doubt about the current situation and how having the same behavior will change something. So if you can have this insight into the person that by doing always the same, it will not go better. And if the person is willing to change something, then it's sometimes the first step to change this misconception. But it's really, really hard work with some patients, and it's sometimes easier in some other patients.
Fantastic, thank you. We did have a question in the Q&A area, which I can answer. Will we be able to view this later and share it with our providers? Absolutely. We are live streaming right now on our Facebook and our YouTube page, so you can go back, and our website as well, I apologize. So you can go back and view it whenever you're ready to share with your providers. How does one who ages determine the difference between arthritic pain and a bleed, and when to treat it?
Yes, I think, of course, that's the big question in the community. I do know that based on symptoms, self-reported symptoms alone, this differentiation is not reliable. Luckily, in the developed countries, you do have other options, such as the ultrasound devices. And I expect that in the future there will be developments as well, and that some kind of apps will be created to help the person to differentiate this. But based only on the symptoms, it's not reliable. So if you do not have the possibility to check the presence of a bleed, you cannot be sure. Now, you can also see this differentiation from another point of view. With the new treatments, you really have an annual bleeding rate that is drastically reduced. So the chance that it's a bleed is less and less. And that's another way of looking at the problem. If you have a proper treatment, if you have a person that is adherent to the treatment, you see in studies that they are really approaching the annual bleeding rate of 0. So it means that there is not much chance that it's a bleeding episode. But I do not have a right answer for the moment, because we know that based on the symptoms alone of pain, swelling, red, it's not really reliable.
Great, thank you. How can patients advocate for a more holistic approach to pain management with their healthcare providers?
Again, an excellent question, and I think it's not only the job of the persons suffering from pain, but it's work that has to be done from the community and maybe also by the government, because I know that in some hemophilia treatment centers, the time is very, very limited, and we do not have the financial resources to give this appropriate treatment plan. I do think that there are some possibilities. So, for example, physiotherapists are often very well trained in assessing and management pain. So it might be an option to just add a physiotherapist with some pain experience to train them in the hemophilia community, and to include them in the multidisciplinary team. To include physicians with a very specific expertise in pain, it's really difficult. The waiting lists are extremely long, and in some centers it's just not possible. But I think we should share the knowledge, because this kind of webinars is really important in make a kind of sensibilization of the healthcare providers and the patients. So I think if we start like that, we will set up small steps, and in the end we will change something. So I'm very happy that this session is being recorded and that you will spread it, because it's the first step for me that people suffering from pain and their treating healthcare providers are aware of this new knowledge.
Great, thank you. Let's see, we've got quite a few more. Can these interventions be done via telemedicine or video conference and have the same results?
Yes, as I said in the beginning, I have a lot of experience in low back pain before entering the bleeding disorder community, and there we have this approach where we did blended learning pain neuroscience education, meaning that it was sometimes physically, and a lot of stuff was done by e-learning, and this works really well, as long as you tackle the individual aspect of the person. So I think part of this should really be individual. So you have a face-to-face exchange with a healthcare provider, and you can also include some more general pain messages with videos and stuff like that. But part should be really individualized to the person, but it might be online. It's about talking, so it can be done by phone or by video conference, no problem.
Wonderful. Okay, so the WFH recommends that people rest the joint when there is an acute joint bleed. How can I exercise as you suggested when I have acute joint bleeding and joint pain?
Yes, of course, as I said, the first step is to exclude a bleed, because that's always the first step. And if a bleed is present, you should stick to the recommendation of the hematologist or the physiotherapist who is following you. So I'm not convinced that in case of an acute bleed, you should do a lot of exercise. That's not what I said. But I think that the chance that people are in developed countries suffering from acute bleeds is less than the pain they will feel from other reasons. So my advice would be, if the bleeding has been confirmed, you should be very careful in the first weeks and try to be progressively increasing the load on the joint or the muscle. But if you are not suffering from a bleed, then there is less a problem to be active in the early phases. And as I said, pain intensity is not a good parameter, because people with osteoarthritis not suffering from hemophilia, they do have this large fluctuation. So one day they are extremely well and they have no pain, and the other day they are suffering from intense pain and they do not know to what is linked. And even in those patients with severely damaged joint, we do ask them to move the joint, but not in an acute bleed. That's, I think, not good.
Okay, great. Is there a role for shared decision-making approach to pain management in hemophilia?
Certainly. I didn't cover it because of lack of time, but I'm strongly convinced that shared decision-making is one of the possibilities to increase the participation of the person. I just give you an example, again, from the low back pain literature, because there we have more literature to use I would say, to argue the point. In low back pain, it is known that exercise is important, but we cannot demonstrate any superiority of one type of exercise, meaning that it doesn't matter what the person is doing, if it's endurance, if it's walking, if it's swimming, cycling, fitness exercise, as long as the person is doing it in the first phase. So there, I think shared decision-making is a very good option if for the person it's not possible to go to a fitness center or to a swimming pool, but walking is a possibility. And a person with hemophilia, walking can be a problem, but maybe cycling can be, home cycling can be a possibility. So in the first step, it doesn't matter what exercise is done. To set up, I would say, some physical activity. If you go to the I would say more advanced program where you really want to have this descending system activated to decrease the pain, then we have to include some more variation. But the first step, it doesn't matter, and it can be something that the person likes. So shared decision making is certainly an option. Also, sometimes to have this discussion about surgery or not, because surgery is sometimes a very good option, but sometimes it takes 1.5 years of rehabilitation afterwards, and that's a very long and painful period. And if you explain these aspects of the surgery, it's sometimes for a person better to have a conservative approach. So yes, the answer is definitely yes, shared decision making is extremely important in this situation as well.
Great, thank you. I thought I heard in the past that each person feels pain differently. How can general principles be applied when there is so much diversity in pain perception?
Yes, again, a very good question, and I will try to use a concrete example. Imagine you are suffering from a headache and you have a boring evening from work or from something else, and you really do not want to go. The chance that you will suffer from the headache and say, okay, I'm not able to go is much bigger than if you're facing a very nice event and you're really wanting to go. Then you will maybe put the same headache a little bit aside, and you will convince yourself that it will be possible. So for one person, depending on the context, you can have different behavior. So it's extremely important to take these individual factors into consideration. And what will block one patient will not block the other one. So I think that pain is an individual problem, but if you have different measurements of the same person, you can have an effect, or you can see an effect, because for this person, the context remains the same, or the values remains the same. So it's mainly based on longitudinal research in the same person that we can conclude the effect of a program, than comparing between the persons, because between the persons is much more difficult, because what is important for one is not important for the other one. So I really think that the studies that have shown the effects it's because of a longitudinal approach for the same individual person. But indeed, there is a high variability, and we need to yeah, to combine different approaches to have the best result, I would say.
That's fantastic. Thank you. Okay, so I would just like to thank you one more time for taking the time to join us this afternoon and for your presentation. That was amazing and so thorough. We appreciate your time and your expertise. And I'd like to thank each one of our viewers for joining us again this week. As please note that this recorded webinar will be available on Friday, July 1st at haemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for a weekly Wednesday webinar series. Thank you for joining us this afternoon and have a wonderful week.
Bye.
Bye, thank you.